Okay, so you're working in the emergency department when EMS dispatch radios announce they will be arriving to the ambulance bay in 10 minutes with a patient who has multiple gunshot wounds to the chest and abdomen. EMS states the patient is AAO and vital signs are stable. They've established one IO access in the right humeral head.
Okay, so first I'm going to prepare for the patient. I'm going to alert the trauma team and get the room ready. I want to warm the room, get a fluid warmer and some blood tubing in case we need to transfuse. I'm going to don appropriate PPE and make sure my team does as well.
Okay, so the patient has arrived. You notice he's minimally responsive with a GCS of 7 and has unilateral chest wall movement with absent breath sounds over the right side. Vital signs are blood pressure of 80/68, MAP of 58, heart rate 135, respiratory rate 22, and O2 sats are 87%.
Okay, I'm going to do my across the room observation. I see some obvious signs of hemorrhage since he has some gunshot wounds, so I'm going to go ahead and apply pressure dressings taped on 3 sides to each of the sites and make sure that the hemorrhage is controlled. Did this stop the hemorrhage?
Yes.
Okay, so now I'm going to start and do my primary survey. So first I'm going to look for alertness and airway. So what is the AVPU for this patient?
The patient is currently minimally responsive to pain.
Okay. So now I'm going to look in the airway and I'm looking for patency, or if there's an obstruction, it could be the tongue, edema, blood, vomit. What am I seeing here?
So the patient's tongue is partially obstructing the airway and you see a small amount of blood.
Okay. So I know at this point I'm going to need to insert an airway adjunct. So I'm going to go ahead and size the oropharyngeal airway, and now I'm going to reassess for patency. Is the airway patent?
Yes, airway is clear.
Perfect. So now I'm going to move on to breathing and ventilation. So first I want to see, is the patient breathing spontaneously? What is their respiratory rate and pattern? Is there bilateral chest rise and fall? And do I hear bilateral breath sounds?
So the patient is breathing spontaneously. He has unilateral chest wall movement. He has shallow respirations with a rate of 22, and he has absent breath sounds over the right side.
Okay, so since he has absent breath sounds on the right side and on symmetrical breath rise and fall, I'm going to perform needle decompression since he might have a hemo or pneumothorax, and I will place a 14 to 16 gauge needle in the second intercostal space of the midclavicular line. So that would be like about here. And then now I'm going to reassess the breathing and ventilation, and
So the patient is spontaneously breathing. He has bilateral chest wall movement, and you hear breath sounds on the formerly affected side.
Okay, so now I can move to circulation and hemorrhage. So I originally controlled the hemorrhage, but I'm just going to reassess and make sure that that's still intact. Is it?
Pressure dressings are intact and there's no obvious signs of hemorrhage.
Okay, good. So now I can check the central pulses. So I'm going to check the carotids bilaterally and the femorals bilaterally. And what did I feel?
Patient has +1 thready central pulses.
Okay. So now I'm going to look at the skin color, temperature, and moisture. And I'm going to feel for that. What do I see there and feel?
Skin is pale, cool, and clammy.
Okay, so based on that assessment, I'm going to want to insert another IV site so I can give a bolus of isotonic crystalloid fluids. So I'm going to put an IV site in the right antecubital space or the left antecubital space and give a bolus of fluids. And now I'm going to reassess the circulation at this point. So looking at his central pulses and his skin color, temperature, and moisture, and what am I seeing there?
So he now has +2 pulses bilaterally. Patient's color is appropriate for ethnicity. Temperature is still cool but warmer than before, and skin is dry.
Okay, perfect. So that looks better. Now I'm going to do an abdominal assessment. I'm going to palpate the 4 quadrants. I am going to inspect the flanks. I'm going to put pressure on the iliac crest, downward and medially, and put pressure on the pubic symphysis. And now I'm done with that. Okay. So now I'm moving to disability. So I know the patient has a GCS of 7.
His eyes open to pain and he withdraws from painful stimuli.
Okay, so now I'm going to assess his pupils. And
His pupils are equal and reactive.
Okay. So now I'm going to go ahead and get a full set of vitals.
So heart rate is 105, blood pressure is 100/75, MAP is 83, respiratory rate is 17, and O2 sat is 91%.
Okay, so based on his respiratory rate and sat, I'm going to go ahead and put on a nasal cannula with a couple of liters and see how that does. So now I'm going to reassess the respiratory rate and pulse ox.
Okay, so SpO2 is now 95% and respiratory rate is 16.
Okay, so next I'm going to give comfort. I'm going to facilitate family presence if possible. And now I'm ready to move to labs. So I'm going to want to get H&H, a blood type and screen, some electrolytes, a lactate, and a blood gas. And next I'm going to go ahead and want to put on monitoring devices. I'm going to go ahead and put a telemetry leads on him to make sure that I know his cardiac rhythm, and go ahead and put a pulse ox so I continually know what that is, especially since we're giving him oxygen via the nasal cannula. And then moving to naso or orogastric tubes. The patient won't be needing that since he is not intubated at this point. And next we move to weaning oxygen and assessing capnography. So since the patient's SpO2 is 95, I don't feel like we should remove that, but I'm going to attach the capnography to the nasal cannula so we can assess that. And what was the capnography reading?
37.
Okay, so that's within normal range. So I can move next to the pain. So I'm going to assess pain using an appropriate scale, and I'm going to apply non-pharmacological interventions, such as repositioning the patient and possibly some pharmacological interventions like Tylenol to help with pain. But at this point, I'm done with the primary assessment of this patient.